Good morning. I'm Dr. Srilekha from the Department of Conservative Dentistry and Endodontics. My topic for presentation today is obturation technique. So what is obturation? The term obturation denotes to close or obstruct. The final step in endodontic treatment, which involves the sealing of apical foramen at cemento-dentinal junction and all portals of entry to periapical tissue. So when to obturate? Adequate biomechanical preparation has been completed and confirmed. Tooth is completely asymptomatic and the canals are dry, no foul odor and intact temporary filling, and no sinus tract evident. But recent research says that even if the sinus tract is present, it is okay to obturate. The rationale of obturation, according to British Dental Journal, is a triad which includes the prevention of coronal leakage of microorganisms into any residual microorganism, prevention of percolation of periapical or periodontal fluids. So according to Grossman, obturation is defined as an hermetic seal. Schilder, it is a three-dimensional filling, and Ramsay, it is a fluid impervious seal. So the obturation should be a fluid tight, fluid impervious and bacteria tight seal. So the apical extent of the obturation should be, like, it can be defined in three things. Like it is short obturation, flush or long obturation. Short is more than 2 mm short of the radiographic apex. Flush is 0 to 2 mm within the radiographic apex. Long is extruded beyond the radiographic apex. The ideal area or the ideal extent of the obturation is that it should be 1 to 1.5 mm short of the radiographic apex. So the classification of obturation techniques according to Grossman includes cold lateral condensation technique, warm vertical compaction, continuous wave compaction, Mexpad and thermomechanical compaction, thermoplasticized gutta perca injection, carrier based gutta perca, which includes thermophil thermoplasticide and simply fill sectional obturation, and chemically plasticized gutta perca, and the eighth one and the final one is the custom cone technique. So in this discussion, we will be seeing about the cold lateral conduction and warm vertical compaction. So the classification of obturation based on number of core materials that is used is single cone technique or multiple cone technique. Based on direction of compaction, it includes lateral or vertical. Based on temperature of the core material, it can be a cold or warm compaction. Based on the need of sealer, with sealer and without sealer, and based on instrumentation of canal requiring instrumentation and one not requiring instrumentation, which is otherwise the example is vacuum obturation technique. So moving on to the lateral compaction technique of cold gutta perca, it is described by Garound et al. The spreader plays a crucial role in size determination. The primary point, otherwise called as a master cone, is selected once the step back technique of preparation is done, and accessory point size determination determined by the spreader, which is used for laterally compacting the master cone and drying the canal, and followed by mixing and placement of sealer, and followed by the master cone placement. The spreader selection within 1 to 2 mm of the true working length. It should be short of about 1 to 2 mm from the actual working length, and to match mainly why it is done is to match the taper of the preparation. So this is a schematic representation of cold lateral compaction, which includes the selection of the master cone first, and then you have to select the spreader and use the spreader to laterally compact the master cone aside, and then you have to insert the concerned size accessory cone. So this is the cold lateral compaction. Before the placement of master cone, the canal has to be coated with the sealer using lentillospiral. So moving on to the warm vertical compaction, which includes the touch and heat. Example is heat carrier, and then the and system B heat carrier. Warm vertical condensation includes touch and heat and system B. Touch and heat, heated probe shears off the gutta perca, and in this technique we use a plugger to condense the GP apically and laterally. In system B, the heat carrier designed as a plugger simultaneously heating and compacting. So it is example is the continuous wave technique. So this is a schematic representation of the warm vertical compaction. This technique was introduced by Schilder using an heated plugger. Alternate is the touch and heat. Steps includes master cone fits tightly to the radiographic apex. Master cone is cut 0.5 to 1 mm at the tip and retried. Largest plugger pre-fit to the coronal third. Then mid-size plugger is used to condense the GP, and smallest plugger pre-fit to within 3 to 4 mm of the root apex. The canal and the apical third of the master cone coated with a sealer and gently used to place it, and surplus GP is removed with heat carrier down the canal orifice, and largest prugger compacts the warm gutta perca into a bolus, mid-root lateral canal being obturated. Heat carrier transfers heat 3 to 4 mm into middle third of the master cone, and then first selective GP removal. Then mid-size plugger compacts softened heat apically. Second lateral canal is obturated. Heat transfer instrument warms the apical gutta perca. Second selective GP removal is done, and the smaller plugger is used to compact the apical mass into the apical preparation and accessory canals. Radiograph confirms the total obturation of the apical third. If the post is to be given, obturation is completed. To complete the obturation by segmented GP, 3 mm section placed and cold welded with a medium-sized plugger to the apical mass. Then heat carrier warms the first backpack piece, warmed piece compacted to the apical filling, and the process continued until the canal is entirely filled. If the plasticized gutta perca is used for backfill, injected and compacted to the canal orifice. So final compaction of the backpack with a larger plugger. So GP and sealer removed to below free gingival level, and final restoration is placed in the coronal cavity. So this is a schematic representation of the warm vertical compaction technique, where first we will be filling the apical third, then followed by the middle third, and then by the coronal third. So this is how the filling goes. So advantages of warm vertical compaction is that most effective in filling the canals in severely curved routes, route with accessory, auxiliary and lateral canals, or with multiple foramina. Three-dimensional obturation is achieved because you're just melting the GP and condensing it so that it gets pushed into the lateral canals, and less stress concentration than the lateral compaction. So disadvantage is that it has to be properly, it is technique sensitive. Sometimes if you apply more heat, it may extrude beyond the apex too. Less lead control than the lateral compaction, and potential for apical extrusion. Intracanal temperature rise may be sometimes a threat. So this discussion was about the lateral compaction technique and warm vertical compaction with a schematic representation. Thank you.